Hi, so happy to be here and help kind of present today with Nat. I'm going to see if I can get my screen to share here. Every platform's a little bit different, so let's see if I can make this work. Let's see here. All right, are you guys seeing my screen?
Not quite yet.
Okay. That does happen sometimes. Let's one second. Once I try to share, I like lose everything on my main screen and then I can't get back to the share thing. So it is always a fun experiment trying to get this to work.
We are all right there with you with technology these days. It was exciting and cool at first, and now it's just annoying.
I know. Oh, let's see here. Screen. Oh, goodness gracious. This is just, there we go. Okay, are you seeing my screen now?
Yes, looks great.
Perfect. So I'm going to turn my camera off because my bandwidth often does not work so well once I turn my screen on. So I will come back when we're done and you guys can see my face again. All right, so I am Jessica Stout. I work on the Child and Family Behavioral Health team with Oregon Health Authority. And Nat, if you want to introduce yourself.
Hi, everyone. My name is Nat Jacobs. I work alongside Jess, and I help oversee the wraparound programs across the state. It's good to be here.
And I'm going to preface this with the fact that we have a lot of information in these slides, and we're hopeful that some of it we're going to go through pretty quickly, but we're hopeful that these slides will end up kind of being a resource for you guys to keep on going, that you guys can go back and access. And there's a lot of links in here to kind of go back and access some of these pages and get more information. So if some of this stuff we go through really quickly, it's really just because we want this to be an ongoing resource, because we know the behavioral health system can sometimes be a little tricky to navigate at times. And so we want to give some kind of tips on how to do that. On the front here, we do have the link to our main Child and Family Behavioral Health website. And so on that page, you will be able to find information on all of the programs that we're going to talk about today, and as well as all of our contact information for our whole team. And as you can see, and it did move slides, right? Awesome. So as you can see, our team is actually pretty big. And so Nat and I are just two of the individuals on our team. And so a lot of the information was actually pulled from quite a few of our coworkers. So we are probably not going to do it complete justice, but that's part of why we're including a whole bunch of links so that you guys will have access to kind of the main pages for some of these specific programs. And in terms of agenda, we're going to spend a little bit of time just kind of going over coordinated care organizations, which is the managed care for OHP. We'll talk about the overview of the children's mental health system and kind of all the different levels of care within that system. And then we're going to talk about some specific programs within our team that we all oversee. And on this slide, we do just have some information or data that was pulled from our dashboard, system of care dashboard, that just shows kind of the number of youth that were served by both the intellectual developmental disability services as well as receiving behavioral health throughout kind of the months. And so this goes through December of 2020. And you can see that it kind of ebbs and flows a little bit, but it's really between 15 and 18% of youth that are in IDD are also accessing the behavioral health services per month. All right, and I'll let you talk a little about coordinated care organizations, Nat.
Yeah, so we thought we'd start off with some shared language and shared understanding about what CCOs are for those that aren't super familiar with the terms. So coordinated care organizations started in Oregon in 2012, and CCOs offer Medicaid services. So they are behavioral health, physical, vision, and dental. And they are, as the name suggests, all really interconnected. So the idea is that you have a local OHP network of providers that you can reach out to when you need services and support. And right now we have about 15 CCOs in the state of Oregon. And the next slide will show you a map, which is something that I have hanging in my queue because I work with CCOs super often. Jess, will you move it forward? So this is what our state looks like, divided up by coordinated care organizations. You can see that Pacific Source has about 5 different sections of the state that they work in. So Pacific Source and EOCCO, the Eastern Oregon CCO, take up the majority of our state. But for those familiar with communities in the Tri-County, Health Share and Trillium share probably the largest population of OHP members.
And then this is just kind of a breakdown of the children's mental health system in terms of the increasing and intensity or increasing level of care. And so it goes from, you know, the intensive care coordination or wraparound all the way to the secure children's inpatient program, which is the highest level of care for children. And so we're going to go through each one of these a little more in depth here. And then in terms of some of these services, so the lower levels of care are generally self-authorized services, meaning that the person or the family can seek these services out without getting pre-authorization or prior auth. And so that would include things like just your standard outpatient therapy, which is, you know, usually office-based, once a week, maybe once every couple weeks. It can include psychiatric services as well, but it's kind of that lower level of, you know, just occasional therapy services. And then intensive outpatient services would be a step up from that. And that is generally self-authorized as well, where families don't have to get prior approval to seek those services. And those are kind of like the outpatient service with some additional skills training attached to it. And those can be community-based or office-based. And then as we get into some of the higher levels of care, those do require prior authorization. So that would be reaching out to the insurance or the CCO in order to get authorization to seek these services. And so that would include things like intensive in-home behavioral health, which is a new level of care in Oregon and is still getting established. And we do have a more in-depth slide on this specific service, just as it is pretty new in Oregon and, like I said, still getting established. And then psychiatric day treatment services, that is a day program that's really psychiatric in nature, but does have an academic program. And they provide therapy, psychiatric services, and skills training, but it's more of a psychiatric program than an academic setting. So these are run by mental health agencies versus some of our like therapeutic schools that are actually run by the school district. So that's kind of what separates those two different types. They're similar in some ways, but these ones are more on the mental health side. And then as we continue going up level of care, we have psychiatric residential treatment services, or PRTS, and that's what a lot of people just refer to as residential, mental health residential care. And so those are for individuals or youth that have significant mental health disorders and require 24/7 psychiatric care. So they really, you know, have safety concerns that need that constant supervision. Typical length of stay is around 3 months, but it really does vary pretty tremendously depending on the needs and the medical necessity of the youth. And then above that is subacute, which is more of an urgent type of stabilization, but it's still residential. And usually that's shorter term because it's really focused on stabilization. And then acute care is our psychiatric hospitalization. So places like Unity or Providence Willamette Falls, those are kind of the ones that do work with children in our state. And those are accessed through the emergency department and generally only authorized for a couple days at a time. And then I'm not going to go through this whole slide, which is part of why we're sending these slides out as a resource, but the most intense level of care, or the highest level of care in Oregon for children, is our long-term psychiatric care, which in our state we call it SKIP and SAFE, and that is the secure inpatient programs. And those do have a lot of qualifying diagnoses and a lot of different things that must be met in order to access that level of care. And so, like I said, I'm not going to go through all of this information. It's pretty overwhelming, but we do have all of it here. And if you do have further questions, by all means, please reach out to any of the links that are on here, as well as myself or Nat. We can also help get you in touch with whoever needs to be in touch. And then the other thing that we thought would be really important to kind of talk about a little bit is what's called the prioritized list. And so this is kind of hard to explain, but it's basically all diagnoses or all kind of conditions are on a list, and the legislature decides where the line is in terms of what is going to be funded. And that is set by the legislature. They review it every couple of years. The current list is funded lines 1 through 471. And I do have the link on here for the list. You can actually look at it, pull it up. And I have a little snip at the bottom of kind of what it looks like. So it's not the most engaging, fun document. It's quite long, and it's just full of words and numbers and can be kind of not super fun to look at, but it does have a lot of really important information in terms of what diagnoses are paired with what type of service. And so I know sometimes what we hear is people will refer to like residential level of care, and they might be told, well, you don't have a billable diagnosis for this service. And this is what they're talking about, is making sure that there's a diagnosis that actually pairs with that service or that level of care. And so, for example, ADHD is above the line, but it's paired with subacute, which is the H2013 code, but it's not paired with PRTS. And so somebody that is needing residential level care, if their only diagnosis is ADHD, they're not going to be able to get into a PRTS setting because they don't have a billable diagnosis for that level of care. And so we do have, like I said, the link on here. It's kind of fascinating to look to see what is paired with what, but it's also a little daunting to look at. And it is a very long document. So there is that. And then we're going to start. We also have a poll. So if we can launch our first poll here.
Lots of good answers. We have about 100 people out of 140 that have answered so far. So
Nice.
I'll give it about 15 more seconds. Okay.
Nice. About half people are somewhat familiar, some not at all. Great. And then if you want to launch our second poll as well, that'll kind of relate to some of the upcoming slides. I just totally mistaken and forgot to launch that first poll right at the beginning because I lost all my notes when I shared my screen.
Okay, second poll is up. We have about 73% that have responded. Okay, it seems like it's slowing down. Do you want me to end it?
Sure.
We have about 80% that have
Okay.
answered.
Sounds good. Great. So it's kind of pretty well split between. Great. So what we're going to start going into now is some of the specific programs that we oversee on the Child and Family team for OHA, and I will turn it over to Nat to talk about wraparound.
Thanks, Jess. So wraparound is the program that I oversee, so I know the most about it and love it the most. I do play favorites. So wraparound has been around in Oregon. There were some pilot projects back in 2009, and it went statewide. 2016, 2018. I think we had some folks in Southern Oregon that kind of came on board 2018, and so we have about anywhere between 30 and 40 wraparound programs, depending on the CCOs and who's operating the wraparound programs across the state. So no matter what county you are in the state, you are able to access wraparound, and each county, each program, because sometimes there's a couple programs in a county, have different ways of accessing WRAP, and I don't have a go-to link for you for that. So I would start with community mental health programs, so your county programs for wraparound, and if you are struggling, you're always welcome to reach out to me and I can get you connected. Most of them have websites though. So wraparound is pretty wonderful, and I think it pairs really nicely with youth that are experiencing IDD because it's a care coordination model. So it's a care coordination model that's hosted by behavioral health, but it's really for youth that are multi-system involved. And what I mean by that are young people that are involved with child welfare. So most of the youth are in foster care, are in special education, maybe they're involved with juvenile justice, and they have a lot of professionals and systems in their life. And the idea is that wraparound helps everyone to be on the same page. So when I've worked with IDD case managers in the past, we've had a lot of conversations around, well, why would we need an IDD case manager and wraparound? And so it's pretty individual. Usually there's some complexity and there's a lot of professionals involved. And I actually have a slide that talks about both at the same time. But WRAP is available for only folks who are on OHP at this time. So we're not able to offer it to young folks on private insurance yet. We're working on making sure that wraparound is accessible to youth on open card, but we're not there yet. Those are future goals. And as long as the person is screened before their 18th birthday, they can stay in wraparound past their 18th birthday. So we have folks that are as young as 5 in wraparound, and we have folks that are as old as 21 in WRAP. So the idea with wraparound, so it's a fidelity-based care management process, and it's got 10 principles, 4 phases, and it's unique from other care coordination or case management models. So we use needs and strengths. We use a robust brainstorming process to help kind of figure out what needs are. So a good example is sometimes people say, well, this person needs therapy. And so wraparound would come in and say, well, therapy is it's a strategy. So what's the need? The need might be self-regulation, or it might be to be less anxious. And so wraparound does a really nice job talking about what folks need and then brainstorming it to figure out what some potential supports are. And they're not always formal services. Sometimes it's really informal. So the next slide just covers the principles of wraparound and my experience working with folks in IDD, the case managers and other staff, is that you all used to person-centered planning. And so wraparound's really complementary in that way. And we center all of those principles when we're working with youth and families. The next slide talks a little bit about when you have wraparound and IDD at the same time. So the frequency of meeting is wraparound meets sort of minimally once a month. Usually in the beginning, it's usually once a week, several times a week. It's a pretty intensive process versus the usually the monthly meetings when you're updating the ISP, or yearly. Sorry, not monthly, yearly. And wrap ideally is 12 to 18 months long, depending on the process. It's not meant to be 2 to 3 years, but you see a lot of teams that have been meeting for that long. And we also have a lot of access to flex funds. So it gives some creativity to some of the brainstorming process. So that's wraparound. Feel free to reach out to me if you have any questions, or if you're not sure how to access wrap. The next program is run by our coworker Lori Theodoro, and PCIT is parent-child interactional therapy, and it's designed for young folk, like little ones, so 2 to 6. And the idea is that you have like a parent and caregiver who's going to work really closely with a therapist. So it's a 2-phase therapeutic approach. The idea is that it focuses on attachment and supporting the parent to address what some people call disruptive or challenging behaviors that get in the way. So PCAT is pretty amazing. There's usually a therapist in one room, and then you have the family and the young person in the other, and the therapist is talking to the parent through usually like an earpiece or some other mechanism. So the idea is that the parent is getting in the moment support. So for young folks experiencing autism or developmental delays, PCIT can help with social awareness, adaptability, positive affect, functional communication, to reduce atypical behaviors. For youth that experience trauma, and children receiving speech therapy who have stalled in their progress. So PCAT is a pretty great intervention for littles 2 through 6 who have a parent involved. And a lot of the time, there's usually some disruption in the relationship between the parent and the child. PCIT is clearly, there's many more sites over on the western side of the state. Looks like you're in luck if you're in northern Malheur County. And there's lots of research on this evidence-based model. The next program is a program that Beth Holloman oversees, and it's the newest of the programs in Oregon. It's a new level of care as well. So for folks that have been working, who have youth that have been in the behavioral health system, maybe you all remember intensive outpatient. And so this is sort of a step up from intensive outpatient. So this is also for youth in OHP between 0 and 20 with pretty intensive behavioral health needs. And similar to wraparound, we're looking to have 2 or more behavioral health diagnoses, impact on multiple life domains, and the safety risk, and or a risk of transition from out of home placement. So this is going to require some information from the documentation from the therapist. I see a question that just came in. Are we answering questions now or waiting till the end? I'm happy to try and answer questions now. Caitlin or Jess?
Yeah.
That's up to you all.
Oh, I'm flexible. I feel
Same
like
here.
yeah.
I'm good with the conversation.
All right. The question from Christian is, would this fall under someone with health needs, behavioral issues, and a behavioral support plan? And I'm not sure if this person is referring to this previous slide. Do you want to unmute and share a little bit more about your question?
So I have a kiddo who has pretty much everything that was on the slide previously.
Okay.
Mental health, behavioral health, the risk of losing home because it's foster care, all this stuff. Would that support in there be helpful to them?
Mm-hmm.
And
Yes.
does it matter what kind of home situation that they are in, if they're like in a child welfare home? Okay.
No, actually the next slide is it might answer all of your questions too, because
Okay.
youth can be in BRS, a DD group home, respite care, TAY. So yeah, there's no restriction on where the youth is living at the time.
Awesome. I'll let the caseworker know.
Yeah. It's still new and it's getting, I think it was implemented, either it was meant to start January, and I think because of COVID, there were some delays with implementation. So I think it's somewhere between, maybe some started in January and then some started in July. So some of what a young person would receive while they're in IIBHT is case management, psychiatric services, therapy, peer support, skills training, crisis support. And I think there's a certain number of contacts that the therapist needs to be in the home for this to meet criteria. So it's not once a week, it's not once a month, or it's like several times a week. I think there's skills training and therapy, and it's all. Jess, do you know the details on the frequency of that?
I don't know all of the details, other than I know it's a step up from the intensive outpatient, which was usually about one time with a therapist and usually 2 times with a skills trainer. So you're looking at probably at least 3 contacts per week on average between all the different providers. And then the medication management is also, can be anywhere from every couple weeks to monthly, depending on what's needed. So that's also a little more intense than your typical med management, which is usually about once every 3 months.
Yeah, thank you.
And then our next program we're going to talk about is the Crisis and Transition Services, which is also overseen by Beth Holloman. It's often referred to as CATS. So if you hear it called CATS, that's what they're talking about. And this was set up as like a diversion for emergency room boarding. And so referrals are made directly from the emergency room or from crisis clinics. It's meant to be a rapid response and really getting services to youth and families that are experiencing those mental health crises, and helping to kind of get things stabilized in the home to keep them back, to keep them in the community, and not having to, seek out residential care or some of those higher levels of care. It usually includes assessments, safety planning, 24/7 crisis response available. They do provide mental health services, family support, psychiatric services, and care coordination. And then part of that care coordination is getting them set up for ongoing mental health services. So the CATS program is really meant to be kind of a shorter term stabilization type program, but the goal of it is to get them assessed for what those ongoing needs are, and then get them connected to those services and supports that are going to help keep them stabilized and keep them out in the community and with their families, or kind of whatever setting they're in. Generally, it can be provided for up to 45 days. And then right now we have 12 different providers across the state that are doing CATs. And of course, it ends up kind of being mostly along the I-5 corridor, which is where a lot of our services are. But we do have sites in Central Oregon as well as out in Union County. And there's continuing to, be worked towards expanding this further and really making sure that this can be accessed across the state. So there is work being done on that. But currently, this is where it is located, or where we have access to these programs. And then the next one that we're going to talk about is our school-based mental health services. And this is a set of programs that is overseen by Fran Pearson on our team. And it's really pretty awesome program because most kids spend a lot of time in school, and aside from the last year and a half where we've all been at home most of the time, in typical days when things do quote unquote get back to normal, which I'm hoping will happen at some point here, schools really are a great place for youth to receive that mental health service because they do spend quite a bit of their day there. And so a lot of our schools do have mental health services right in the school, or access to services. And some of the benefits of school-based mental health is really having someone to talk to immediately without having to go through the process of scheduling an appointment and trying to get into an outpatient clinic. It removes the barriers to transportation, helps students kind of deal with the crisis issues at the time that they need, because the therapists are right there at the school. And sometimes the school setting can just help the youth feel more comfortable because it's a setting that they're in so often that they already feel more comfortable there, versus having to go out to an unfamiliar environment or a clinic that they've never been to. And then our school-based health services, which is where the mental health providers are often located, is a bigger kind of overarching set of services. And oftentimes the school-based health centers do include things like nursing. They include access to physical therapy, occupational therapy, primary care providers, and many other options. And so we do have this slide also as a handout, so you guys can have access to this as a handout, because there's just so much that is involved in the school-based health centers. And then here is just a map of where the OHA and school-based health centers are located. However, the school-based health centers are not the only mental health services involved in schools. A lot of our schools are connected directly to their community mental health providers, as well as other private agencies within their community, and are contracted with some of those private agencies. So this does not include any of those. So I know places like Trillium Family Services is in a lot of schools in the metro area, as well as in the Valley. Those are not on here. This is really the ones that are overseen by OHA. So it's really good to talk to the local school district to find out what mental health services are available in the particular school that your youth are attending, and kind of see what access is there. And then one of our other programs is ESA, and this is Early Assessment and Support Alliance. And this program is overseen by Let Schneidman. And it is really a program that is meant to work with young people that are experiencing their first episode of psychosis. And so it's an intensive multidisciplinary approach during what they're calling the critical period, where the intervention is most effective and can prevent kind of those long-term consequences associated with chronic psychotic illness. It's meant for youth and young adults aged 12 to 27 and their families. There is a really strong family component because we know how much family support and having parents that understand psychosis can be so incredibly beneficial for supporting the young people. And so they do have a lot of family supports built into the program. The criteria for ESA is pretty stringent in terms of kind of what their criteria is. And it is they have to have some form of schizophrenia spectrum disorder or a bipolar disorder with psychosis. Diagnosis has to be within the past year, and then psychotic symptoms can't be related to substance use, trauma, or major depression. They really do need to be related to a schizophrenia spectrum disorder or bipolar. And then one of the things that we are also working on within OHA is eliminating the IQ criteria. So currently there is a qualifier that anybody with an IQ under 70 is not does not meet criteria for ESA, but we are working with ESA, and starting January of 22, that IQ criteria will be eliminated. And then we are also providing some additional support to ESA right now on understanding IDD and how to support and how to recognize psychosis in individuals with IDD. So I think that's really important for this group to know, but they will still have to meet all of the other criteria for ESA in order to get into this program. But I think it's such a huge win to get rid of that IQ criteria, and I am very, very, very excited about that. So that is fantastic. And then there's 29 sites across the state of Oregon. So almost every county has ESA. There's a few counties over in Eastern Oregon that do not currently have an ESA site. And then we do have the link to the main ESA webpage to get some additional information and to find out, you know, who the contacts are for the local ESA sites. And then peer support, if you want to talk about peer support now.
Yeah, so peer support is overseen by two folks on our team, Frances Purdy and Lev Schneidman. And our unit, we are huge advocates of partnering with folks with lived experience because it helps to inform program development and making sure that we're on the right track. So for those not aware of who or what peer delivered services are, they're folks with lived experience who are using their experience to support other people, and they have to be certified as a traditional health worker in the state of Oregon. And specific to youth and families, we have, at least in wraparound and a lot of other programs, there's family partners, which are the family peer support specialists and youth partners that work with youth. And we have two agencies that we contract with. Oregon Family Support Network supports our parents and caregivers, and Youth Era is a great resource for youth advocacy. They have drop-in centers, mostly on the western side of the state. So Eugene, Coos, Clackamas are the three that come to mind right away. They have a lot of online and virtual support groups and information and some really great technical assistance. So reach out to them if that's something that you think would be helpful for youth and families that you're working with.
And then our last slide is just some other OHA initiatives that we are working on to really help try to support the mental health service delivery for youth that are duly diagnosed with IDD and mental health. And so we do have two train the trainer cohorts that are actually starting, one of them starting next week. We have one that's really focused on the adult system and the adult providers, and then we have one that's more focused on our children's system providers. Both of them are in September. Thank you, COVID, for delaying and ending up with them being back to back. It is what it is. And so it is really exciting to, you know, continue to try to train some of our clinicians to be able to really understand how to work with individuals that are dually diagnosed, because that is just a theme that we continue to hear over and over and over again, that our clinicians don't feel prepared to work with this population. They don't feel like they know how to adapt therapy. And so we do have some initiatives to really try to help in that area. It is going to take some time to really get the trainings out there, but we are definitely committed to trying to make things better and helping our clinicians understand this population. And then we have a couple different video series that we're working with the National Association of Dually Diagnosed on. One of them is going to be around substance use disorders and IDD population. I think that is kind of an area that often gets overlooked. And so it's going to be, I believe it's 120 minutes broken down into 20-minute segments. And so I'm really excited to see how that comes out. It should be out probably by October is our goal, is to get that out, and we'll definitely share that with the IDD system as well. And then we also have another video series coming out this fall that is on complex health conditions in IDD, and we will also share that one with our partners over in the DD system. And then, of course, our annual Children's IDD Mental Health Summit. This year, we are going to be doing a 3-part webinar series, and I know it says October 21, but yesterday we made the decision to actually postpone it out to January because of everything that's going on within our systems and trying to find a time that is going to be a little bit easier for people to actually participate in that, because things are just so busy this fall. So we will have a 3-part webinar series coming up in January of 2022, and we'll make sure to get information out to everybody. And I know quite a few people from the DD system attend that every year. And then we're crossing our fingers that in fall of 2022, we can have a really big, fun in-person event, because it will be our 10th annual summit, and we are crossing everything I have that we can be in a place where we can safely meet in person again and have a really big fun summit. So I am going to stop sharing my screen and turn my camera back on and maybe answer some questions.
Jess, can you talk about who can attend the Train the Trainer?
That we already have all of the participants. It is focused really on clinicians to train other clinicians. And so we have folks from some of our community mental health providers. We have folks from some of our private agencies that are signed up. There's folks from pretty much every part of the state. We have a couple from, Central Oregon, the metro area, the Valley. There's a couple from Southern Oregon. So we really try to target it to all areas of Oregon so we can really get that training out across the board. So we do have, I believe, at least one from Eastern Oregon. But with everything being done online now, I think it also really opens it up that we can do online trainings. Even if we don't have a trainer over there, we can get them set up to do an online training with somebody that's maybe not based out of Eastern Oregon. I think if anything good came out of this pandemic, it's that we are all very used to being on camera, and it does really open up the doors to being able to, do that training across the state and not have to worry about driving and all of the logistics of that. So, yeah. Any other questions? I didn't get to see the chat because I lost everything when I shared my screen, so I'm not sure what's in there.
It looks like Nat answered some questions about referrals to that CATS program. But we do have plenty of time for additional questions, experiences you've had with youth that are children and youth that are on your caseloads, and please take advantage of this time while we have Jessica and Nat with us. And you can feel free to raise your hand and we'll call on you, or type in the chat. Okay, I'll get us started. I was wondering what would you expect or need from a DD services coordinator who has a child that's on their caseload that is also served by wraparound or another behavioral health program? Like, what is needed from a services coordinator? What would be the best way to make sure that folks are on the same page and that the child is really, getting the best support and services?
I think for wraparound specifically, wraparound asks that folks are available to meet every month, so that, or at least once a month, to connect around what is going on with the youth and family. So wraparound has sort of a high participation component to it that I would say differs from the other programs that Jess and I presented on today. IIBHT might, they definitely include some monthly meetings with other professionals in the young person's life. So yeah, wraparound is pretty participatory.
Thank you. And there's another question in the chat now that says, with the exception of the ESA program, there's nothing in the other resources or programs that would automatically prevent a youth also involved in substance use disorder from participation. Is that correct?
That is correct. Yeah, unfortunately in Oregon, we see a lot of youth that have, substance use and mental health disorders, and it's a lot of times they're intertwined, and it's hard to see where one starts and the other stops. And so yeah, that is not a preventative. There are a couple programs that they might want them to also engage in substance use treatment in addition to that service to be able to kind of address both needs. Yeah.
Question for more information about intensive care coordination.
Yeah, thanks for bringing that up. So intensive care coordination is something that is offered through the coordinated care organizations, and ICC is sort of what it's known for, what it's called shorthand. And it can be anything from coordinating complex physical health issues and coordinating behavioral health and physical health issues. And it has a lot of similarities to what wraparound provides in terms of the coordination without that fidelity component. So for folks that are not really interested in participating in wraparound, but want to be able to have access to behavioral health resources and have a coordinator who provides some system navigation, ICC is a really great care coordination model.
And Nat, is there specific requirements in terms of if they have to be multi-system involved or how to access ICC?
Yeah, there's, it's something that we don't have anybody on our team who oversees it. And so all I know about it is the language that's in our 410 rules and our CCO contract. And I'm happy to kind of cobble together some of that language, but it's pretty specific. It's multi-system involved, youth in foster care, complex needs, youth that are 0 through 5 that are struggling with school and behavioral health issues. So there's a bunch of different ways you can qualify.
It looks like there's a couple questions in the chat about wraparound Nat. So it says they have a family who says she was signed up for wraparound but has not heard from her person. Is there a way to find out who has been assigned?
Yeah, I would call the wraparound program and let them know that you have no idea who the person is and you haven't heard from them. There should be a pretty tight turnaround between when a youth and family have been referred and accepted into wraparound and when you hear from somebody. So yeah, definitely call the program that you referred to and ask them to get it going, get the party started.
So there was also a higher level than wraparound eligibility. I believe that was from the question previously that you already answered.
Oh, I bet that's related to ICC. Does that have a higher eligibility requirement than wraparound? I think they're about the same, aren't they? Or maybe even a little less.
Yeah. Yeah, I would say that they're pretty similar. Megan, it looks like I'm going to give you my email address and we'll track this down. There's not an actual list, but if we can narrow it down by county, we'll get this.
I don't think you guys answered this one. Maybe beyond your scope today, any guidance or secret decoder ring to offer for getting access to residential treatment for substance use disorders by 18 to 21-year-olds.
Yeah, that
there's
is
a
outside
secret
of our
password.
wheelhouse.
Yeah.
I would love to know that secret as well. If you want to reach out to me, I can get you connected to our adult sub providers that really do that 18 and above, and get you guys connected to the right people on that team. And I think unfortunately, across all of our systems, our capacity is limited right now because of so many of the impacts with COVID, which are really having just a significant impact on, I know the DD system is experiencing that as well. So unfortunately, it's kind of an uphill battle sometimes right now. But we're here to help as much as we can and help navigate and get you connected to the right people.
Other questions? You can talk, you don't have to type it out.
Okay. Well, we might be done a little earlier than expected today. Gift of time that we don't get often.
Well, and like I said, there's a lot of links in the handouts that you guys will be getting, and all of our contact information is on our main webpage, which is on that very first title page of our PowerPoint slide deck. So feel free to reach out, and Caitlin, you guys can also send out our contact information in the email that you send out to the group as well. I'm totally fine with that.
Okay, so yeah, I can copy you, Jessica, and Nat in that email, and I'll BCC all the participants from today, have the survey link for all of you to complete just to give us your feedback. It's really short, so it won't take you more than a minute. And then all these handouts and great resources from Nat and Jessica so that you can follow up and get connected and get the kids and families on your caseloads connected as well. We appreciate your time so much. Thank you.
Yes, thank you all.
Thank you. Bye. Have a great day.
Bye.
Thank you.